So welcome to the ERA Journal Club. Each Journal Club takes place on the last Thursday of the month at 1700 Central European Time. And each seminar has picked out a topic from a recent CKJ or NDT article, and the author or authors will introduce their work. We have at least one expert on our panels, and today it'll be moderated by myself, Will Herrington. I'm an Oxford-based nephrologist, epidemiologist, and kidney trialist. Our discussion will last up to about an hour, and it's fairly informal, but we encourage you to use the live option available to you and type questions into the Zoom Q&A box. This is all recorded. It will be made available on various video platforms afterwards, so keep an eye on social media for links if you want to watch a rerun. So today's session was inspired by a paper provocatively entitled Renal Artery Stenting in the Correct Patients with Atherosclerotic Renovascular Disease, Time for a Proper Renal and Cardiovascular Outcome Trial. And we are very pleased to welcome the author, Dr. Marieta Theodorakopoulou from the Department of Nephrology in Aristotle University in Thessalonica, Greece. Welcome. And Pantelis Sarafidis, who's an associate professor in the same department and a particular expert in hypertension and related fields. Welcome as well. And we're grateful to Professor Darren Green from Manchester, the home of the Astral trial, who's an acute physician with particular interest, long-term interest in renal artery intervention. And Rajesh Gupta, who has given up his Thanksgiving morning to join us from the US. He's from the University of Toledo, which is home of the Coral trial. He has a laboratory interest in ischemic injury as well as this clinical research in percutaneous intervention. Thank you both for joining to share all your knowledge. So today we're going to try something a bit new for the Journal Club. We're going to start with a pre-Journal Club poll. Do you routinely consider CKD patients with possible renovascular disease for vascular imaging plus or minus intervention? And the options are always, sometimes, rarely, or never. Vote now. Darren, Rajesh, Pantelis, Marieta, you're banned from voting, I'm afraid. Wow, about a quarter always consider it, and about 59% sometimes consider it, 15% or more conservative. Let's see if that changes at the end of the seminar. So we've got the world experts together on the call today, so fantastic opportunity. Please do use the Q&A box, and we'll try and answer things as we go, as well as asking the questions directly. Marieta, maybe I could start just by asking you what got you interested in renovascular disease.
Okay, good evening to everyone. My interest is particularly because I'm very interested in cardiovascular medicine in CKD at all, and you can see in the following slides that patients with renovascular disease are at very high cardiovascular risk among those with CKD. So it's a subpopulation of patients with very, very high severe risk. So this is one of the reasons that I'm interested in this. Thank you very much for the introduction. I'm really honored to be invited and be a part of this very interesting session. And here are my disclosures. So let's start with some basic. These are the two major types of renal artery stenosis. We have atherosclerotic RAS, which is the commonest type, and we have fibromuscular dysplasia, which is more common in younger patients, in women, and in children. So in this presentation, we will talk only about atherosclerotic RAS. So the prevalence of ARVD has large differences between different populations, and it depends on the underlying condition, but we still do not know the exact prevalence rate of each condition in patients with CKD. We have some data from studies like this. This is a quite old study from the USRDS, which suggests that just before dialysis, the prevalence of ARVD is about 11%, but this data came back from the late 90s. So it's very possible that the prevalence rates may now be even higher. So in any case, what is really important is this: the prognosis of ARVD in CKD is bad. This is the data from an observational study from RITSI, from a UK study with more than 1,000 CKD patients that suggests that patients with pre-dialysis CKD and ARVD have 50% higher risk for death compared to those with non-ARVD. And after dialysis, this risk is even higher, with 3.3 times higher risk for death than when compared to patients without ARVD. So today we're going to talk about the management of ARVD in these individuals, and we have revascularization and medical and standard medical therapy. And this is something that we wrote in a short commentary in the CCKJ a few months ago, which says that the practice, the patterns of our management changes over time over the last 30 years. So we started here at 90s with a period that the revascularization was over to almost everybody, because the first trials, the first observational studies saw that that all patients benefit from it. But then we have some major trials that tell us that we should not use PTRA for almost all patients. But again, we had then some observational studies saying that in the right patients that the PTRA may benefit it. So we have now some recommendations that change the clinical practice in the field. So let's start with the standard medical therapy that is used in ARVD today. ACEs and ARBs are commonly used as a part of the regimen, but we should remember that we should monitor for the eGFR, and any drop higher than 30%, we should consider to evaluate for critical stenosis in bilateral ARVD or ARVD with a solitary kidney. We should also remember to closely monitoring the potassium levels and achieve BP control. If we not can do it with only ACEs or ARBs, we should add on calcium channel blockers or diuretics. Also, we should use steroids or aspirin for the reduction of the cardiovascular risk that have these patients, but also comply with other lifestyle changes, such as the smoking cessation. So start with revascularization. Preliminary observational studies, this is from the 90s, where all patients were revascularized, so that we have significant decrease in blood pressure and stabilization. You can see here, stabilization of the GFR after the procedure. But then we start to have some clinical trials. And this is one of the first, the TRUSTIC trial, with 106 hypertensive patients and a 12 months follow-up, which showed that both at 3 and 12 months after the randomization, the blood pressure levels between the angioplasty group and the drug therapy group were not different, but we have a significant decrease in the number of antihypertensive agents used in the angioplasty group. The next study is, again, a very small study with 55 randomized patients with unilateral or bilateral RAS and a small follow-up, only 4 weeks, in which in patients with unilateral RAS, no difference again between the two groups in blood pressure, but in patients with bilateral disease, we have again a significant decrease in blood pressure levels after revascularization. Next came the STAR study, the first study with a renal primary endpoint, 140 patients with creatinine clearance lower than 80 ml per minute and a RAS of higher than 50%. So again, no difference in the primary endpoint and no difference in the combined endpoint of the primary endpoint plus death. And then we have the two larger clinical trials in the field. One of them is the Astral trial. 806 patients defined with ARVD defined as a substantial atherosclerotic renal artery stenosis with no further details, with a large follow-up, median of 34 months, and again a renal primary endpoint, which was the change in the mean slope of the reciprocal of serum creatinine. And here are again the major results of the Astral study. No difference in the primary endpoint, no difference in serum creatinine. Here in systolic blood pressure, we have a slight decrease in the early months after revascularization, but after 2 to 3 years, again, no difference between the two arms, and no difference between the two arms with regards to the diastolic blood pressure levels. And then we have the CORAL study, the only study up to date, the only RCT up to date in the field with a primary cardiovascular endpoint with CV or renal death, MI, stroke, the rapid decline in kidney function, and the need for renal replacement therapy. The inclusion criteria were more strict when the trial was designed, with severe atherosclerotic RAS higher than 80% and systolic pressure gradient higher than 20 millimeters per mercury, uncontrolled blood pressure with systolic blood pressure levels higher than 155 millimeters per mercury on 2 or more antihypertensive drugs, and again, a relatively large follow-up period with a median of 43 months. Again, no difference in the primary endpoint. You can see here the curves, and no difference in any component of the primary endpoint: death from any cause, stroke, MI, hospitalization for heart failure. So I'm not going to talk about the limitations of these trials and the problems that may arise from them, but now I want to give you some perspective about with some newer observational trials, some newer observational studies in the field. So a major study from the UK, again from the research group from Philip Carla. It's a retrospective analysis with 467 patients with RAS higher than 50%. The authors here have divided their population in patients with low-risk phenotypes and patients with high-risk phenotypes, and define those with high-risk phenotypes as these with flash pulmonary edema, rapid renal function decline, and resistant hypertension. And in each of the 4 groups, 2 out of 3 patients were receiving the standard medical therapy and 1 out of 3 receiving PTRA. So you can see here that the patients with high-risk clinical presentations with flash pulmonary edema, with resistant hypertension or rapid GFR decline, not only did better with revascularization, but also have a better survival. So this study triggered the question that those with high-risk clinical phenotypes may have significant benefits from revascularization, and if we do not offer them the option to revascularize, this would have significant consequences for them. A few months ago, there was another prospective observational study with 100 patients and a follow-up of 24 months. And the inclusion criteria, again, we have RAS higher than 70% and one of the following, again, high-risk clinical phenotypes: resistant hypertension, rapidly decline kidney function with GFR reduction higher than 5 ml per minute per year, or hospitalization for acute heart decompensation, defined as either as more than 2 hospitalizations for heart failure or more than 1 hospitalization for flash pulmonary edema with negative coronary angiogram and no other obvious explanation. You can see here the baseline characteristics of the participants: uncontrolled hypertension on an average of 4 antihypertensive agents, and the mean GFR levels about 40 ml per minute. So this is what happened after revascularization with regards to blood pressure. a clear drop, a drop about 20 millimeters per mercury that was accompanied by a significant decrease in the average number of antihypertensive medication used from 6 to 2.5. And most importantly, you can see here what happened with the eGFR. Here with the green line, they're the pacing group with eGFR with no rapid decline. And here with the red line, you can see the patients that exhibit a rapid decline of the eGFR. In both groups, after the procedure, after revascularization, we have a stabilization of eGFR. And with regards to albuminuria, you can see here, we have the UACR, which was low, goes up before the angioplasty and again go down at the 12 months after the procedure, possibly following the drop in blood pressure. So after all this data, some question may have arisen, and this include why there is a discrepancy between the RCTs and the observational studies existing in the field. Is this an issue of inclusion and exclusion criteria, or maybe a mismatch between the trial and the real-world evidence? And last but not least, how current recommendations adopt to all the above data? So I think that Professor Sarafidis can now answer to these questions.
So let me thank again the organizers for the invitation. I cannot consider myself as an expert in terms of the studies in the field, but we work in a very large hypertension clinic environment built in a large, at least for Greek standards, department of nephrology. So we get a lot of these patients, and we were prompt to talk about it because we were seeing as everyday clinicians things being changed. These are my disclosures. So I just opted to start from something that is quite simple. This is textbook knowledge. What is renovascular hypertension? It is a rise in arterial pressure associated with stenosis that is at least improved, or even better, eliminated by removal of the stenosis. And if one goes on a little bit with textbook knowledge, this is from Norman Kaplan's clinical hypertension textbook. The actual issue when to suspect and further investigate for renovascular hypertension is actually answered by a few simple clinical hypertension phenotypes. And if you see them, then you can easily tell that these are not different from the clinical presentations of atherosclerotic renovascular disease. So here, if you exclude these people that will have renovascular disease discovered during imaging studies for something different, the coronary angiogram as by chance, and most of them have stenosis that can be around 40, 50, 60, or 70%, and probably don't cause any problems. There are a lot of patients that can have clinically relevant renovascular disease, causing resistant hypertension, progressive chronic kidney disease, loss of GFR during RAS blockade, unexplained acute kidney injury, and this thing, which is probably the most dangerous, acute plus, we call it pulmonary edema. So just to give you again some background in physiology, especially for people that are watching us and are younger fellows, the kidney has a lot of benefits and has a built-in system of autoregulation. So for blood flow to be reduced below 50% in healthy individuals, you need to have a stenosis higher than 90%. And this is because renal autoregulation is capable of keeping blood flow and perfusion pressures into a certain level. Of course, we know that in the elderly or people with diabetes, dyslipidemia, hypertension, whatever, the autoregulation can be significantly impaired. But then it is very unlikely a stenosis of around 40 or even 50% or 60%. to give you some critical reduction in blood flow. The problem here is that we don't know exactly when the degree of the stenosis is definitely associated with a drop in renal blood flow and clinical consequences. And when it comes to pathophysiology, this is a very nice figure from a very nice review coming from a controversy conference of Vigo. We know relatively a few things about the actual mechanisms of development of ischemic renal damage. We know that oxidative stress is there, inflammatory cell infiltration, whatever. But for this paradigm of chronic kidney disease, we don't know a lot. We know much less than, for example, the exactly opposite, the paradigm of glomerular hyperfiltration and proteinuric CKD. We are hoping that new things coming in, such as the bold MRI, can give us some opportunities to identify patients, but again, this is not very widely examined. If you hit the PubMed, you will find 10 to 15 studies using bold MRI in renovascular hypertension up to now. So let me just give you some examples of what can be considered as technical limitations of the previous studies. And I'm saying that these studies were great. They try to give us some answers, but probably we should interpret them in a context of what is happening today in the real world. So I'm starting from the drastic study, which randomized patients to angioplasty or to drug therapy. And I'm also using this study when I'm teaching in clinical trials design in a local master's program, because this is one of the relevant studies that had a higher crossover rate. So from group B assigned to drug therapy, 22 patients needed angioplasty, so 40% of patients. So what happened was more or less this one. A lot of patients in the medical therapy group had occlusion of affected arteries and a very high increase in serum creatinine, and then almost 50% of them, 45% of them needed revascularization. So this can tell us a lot of things about the actual situation here, that probably a lot of patients would need revascularization one way or another, but actually makes it very hard to repeat the actual study results, showing no difference between the two groups. Further studies, we have here the STAR study, and Dr. Theodorakopoulou told you about the results. But if you want again to have a closer look from those patients randomized to PDRA, 12 did not have even stenosis higher than 50%, so they had no stenting. Another 6, they had no stenting for various other reasons. And another 22 had stenosis of 50 to 70%. So more or less, 40 out of 64 patients in the revascularization group either did not have revascularization at all or had stenosis that were very unlikely to benefit. With this and that, we go to the big trials. So this is the Astral study. And the Astral study is a very important study. And I believe that the actual investigators here wanted to have the best possible results and wanted to avoid the problems of previous studies, for example, the drastic study. So they included patients that had a substantial anatomical stenosis, at least in one renal artery. That actually probably was made to avoid including the patients that should definitely go for revascularization, to avoid the problems for drastic that the drastic study had. And this is probably an honest attitude in terms of including people. And again, they had another criterion if the patient doctor was uncertain. So that was probably there for patients that the doctor would be certain that they need revascularization not to be included. So to focus on the actual people that we didn't know what the result would be. So both of them were honest and all right. However, in the real study world, this led to a mean degree of stenosis at about 75%. which also meant that a lot of people, 40% of people, would have stenosis from 50 to 70%, which is again is okay. And the actual patients would have different levels of renal function, and patients with very low renal function, as low as 5 mL per minute, were also included. That led to a lot of criticism. This is not my criticism. These are people writing to the Journal of Medicine, that the trial had probably included patients with low degree stenosis and have excluded patients that were actually needing revascularization. There was no criterion relevant to time, and we know that all stenosis, perhaps if you revascularize them, you don't gain a lot. And in terms of the technicalities, the number of the patients and the amount of time where the study was executed were more or less giving us 1 patient presented per year to be revascularized. But this actually tells us that these studies are very, very difficult to do in wide scale. After that, we had the CORAL study. So the CORAL study built on previous experience and started even better. So all patients had to have severe RAS and had to have resistant hypertension. And actually, the stenosis had to be defined angiographically. So this is very good. This is even better. However, when the study started, there were a lot of problems in recruiting patients. So with time, there were many changes. The requirement for hypertension was no longer specified. Instead, people were enrolled if they have chronic kidney disease, which actually was more or less a smart thing to do, but then a lot of people with advanced CKD can be included. And instead of angiography, duplex ultrasonography was used. And then the result was that the average, that at least 1/4 of the patients were included based on ultrasound, and the average stenosis degree was even lower than Astral at 67%. So more or less, the CORAL met the same criticism with Astral, and this is not my criticism, that patients that should have been included were excluded, and patients that were included, at least those with less than 60% stenosis, were not much likely to benefit. Overall, a lot of people, including myself, have described that these studies have some problems on inclusion or exclusion of the proper patients. And again, it's very difficult to do such studies. So there were enrollment delays, protocol revisions, high crossover rates, and low event rates. This criticism actually does not, how can I put it, does not unjustify these studies and the reason why they were done. I think they gave us some very, very important results. And the main conclusion can be that it's not really relevant. You should not offer revascularization to everybody with renal artery stenosis of any degree. I think this is a very stable and very important conclusion. So what happened after these major trials? And if you see what happened, then you would be probably disappointed. And we actually tried to see what was happening in a recent review we wrote for hypertension on behalf of the European Society of Hypertension. So several studies, starting from 2004, 2009, whatever, have never been completed. Their actual status now on clinical trials database is unknown. And one study from an important French group starting in 2015 was again paused due to lack of recruitment. So it is indeed very, very difficult to do that studies, and investigators of Astral and CORAL have to be congratulated for doing them. What can we expect? I don't think we can expect a lot of interesting things. There is a Chinese study that is recruiting, it has not started recruiting, and it's supposed to be an open label study and a very small, I think this is a Danish study with 30 people, again, an observational perspective study. So, in view of this data, what actually changed our perspective. And I think we should again thank the groups that are active in this field, especially the Phil Carla group in the UK, that try to have very nice observational studies, as you were told already. And this is now followed by other groups, like the study we're connecting to this paper, to tell us that probably we have at least 3 phenotypes: resistant hypertension, flash pulmonary edema, and rapid decline of renal function, that probably the situation is much different. So what I'm going to tell you is very briefly that all these bodies, or these international bodies, have provided new recommendations. This is a very detailed description of the American Society of Interventional Radiologists, what to do with different suggestions depending on CKD states. They rely a lot on this transnational mean gradient of more than 10 millimeters of mercury. It was in Coral 20 millimeters of mercury, but here it's 10 millimeters of mercury. The American College of Cardiology, the European Society of Cardiology, along with the European Society of Vascular Surgeons, the Japan Society of Hypertension, they more or less say the same thing, and they focus on these 3 types of the 3 high-risk phenotypes. And what we have from KDIGO, from this very nice controversy conference, a lot of controversies there, and I think myself and Professor Green was also there. We had this table, which I find at least very relevant of what we should do, and some definite indications and some possible indications were offered. So definitely it's flash pulmonary edema or acute decompensated heart failure, and this is something we have to work to remind our fellow cardiologists. Progressive renal dysfunction with high grade, here it is 75% stenosis. AKI, or similarly on high grade stenosis. Intolerance of an ACE or an ARB with high grade stenosis. And again, kidney transport with any degree of RAS, and I think this is also very relevant. These are possible indications, and these are non-indications. So if you have hypertension only that you can easily control with drugs, or if you just found a low grade or moderate grade stenosis by chance when you're investigating for something else, then it's very unlikely to have any benefit of revascularization, at least at this point. In addition, this controversy conference offered some insight with simple clinical guidance. Perhaps the bold MRI can be added here at some point, on when it is likely to have a viable renal tissue. If we have a length above 8 centimeters, probably we should consider to have that by BMI. If you can see the cortex, if you have low renal resistance index, I'm in personal disagreement with this albuminuria criterion, because in unilateral stenosis, you may have a lot of albuminuria coming from the contralateral kidney that had hypertensive kidney damage or secondary ACS. But again, this can be considered as relevant. And we from the European Society of Hypertension try to make the same point. So if you have these high risk clinical presentations and you have a high degree stenosis, then you should definitely go for revascularization, of course, depending on the actual patient that you have in front of you. So our conclusions in this commentary perhaps is something that all of us have thought, that major RCTs at that time included patients of various degrees of stenosis, and then they have a solid conclusion that we should not revascularize everybody, but these in the medical world was probably not interpreted properly, and a lot of patients with critical stenosis did not receive the treatment they should. Then we have pieces of observational data, and in some cases from the same groups that did the clinical trials, which is something that this group should be praised upon, showing that high-risk phenotypes should be treated, and this led to a progressive shift in recommendations that we should know about. what can we expect? So there is a real question here. So if you ask me, I'm not very much in favor in having a study like that because I probably know the result. But if we want to see what really should be done is to have a big study involving the stenosis that are hemodynamically significant, and to add on that how non-invasive imaging such as bold MRI can help us to identify patients, to see what is happening depending on the degree of chronic kidney disease, to include also the time criterion of revascularization, identify predictors, and possibly evaluating the efficacy of revascularization in combination with new treatments, for example, anti-inflammatory treatments or other very interesting things. And with this, I will be closing. I will leave this last slide of conclusions for the discussion. Thank you very much.
Thank you so much, both of you. That was beautifully logical and so easy to follow. Give us a decade and a half, isn't it, almost, since the results of the trials which started to influence my practice. It's great to revisit them. I feel like I shouldn't be the selfish one to ask the first question, but I want to. I'm interested in the practice of people in terms of screening for renovascular disease. What are the key features that would make you want to screen, and what do you screen for regularly? And then which test is your preferred test? I guess, Pantelis, can I ask you that question first, and then we'll move to Darren and then Rajesh.
If we think that we are kind of more or less seeing these patients coming to us, referring from, at least in my center, from everywhere in Greece or northern Greece at least, with uncontrolled hypertension, the most important thing the first thing is not the most important thing we commonly see is exactly that. It's people that have been going through different specialists and different doctors, from GPs, internists, and then cardiologists, without having their blood pressure controlled. And then the other major source of patients that we see are those in the cardiology departments that we cover. They come back with pulmonary edema, and the coronary angiogram is perfect. So these two types of patients are those that we mostly encounter in clinical practice, and we further investigate them for renovascular disease. And we found critical stenosis in these selected populations, I would say at least 80% of the time.
And just so, what do you do in terms of investigations? Are you doing MRAs in everyone as the first screening tool? Yeah.
So I'll just go first, and then I will stop talking. So for most of our patients, we have also compromised the renal function with TFRs anywhere from 20 to 45 or 50. So we have trained our fellow radiologists, and we have very good quality MRAs. If we have a younger patient with preserved renal function, we can have CTAs. And we found very helpful scintigraphy as well, because this is something that wouldn't affect renal function. And if we have a unilateral stenosis, then it can tell you a lot of the story. You have a 70-30 or an 80-20% between the two kidneys. The problem with scintigraphy is that if you have bilateral disease, which is much more common in patients coming with class pulmonary edema, they can tell you, scintigraphy can tell you a few things, if I may, can be misinterpreted. Now, those three things, I guess it's very easy to do even in an outpatient basis, and you can know your way around from then on.
And I was wondering, Rajesh, if that's the practice in the US. Do you do anything differently, or are we similar over the other side of the pond?
No, I think I concur. I guess just generally, like, when do I think of renal artery stenosis? It tends to be these, polyvascular or vascular path patients. So I look at, smoking history is a big one, very predictive. I look at vascular disease in other vascular beds, so coronary, carotid, or peripheral vascular disease. And then the phenotypes that are kind of potentially relevant are resistant hypertension and potentially a recurrent heart failure phenotypes. In diagnostic testing, we typically use duplex ultrasound just because it's benign, non-invasive test. There's no contrast involved. And frankly, since Coral, I think unless you're interested in the disease or potentially doing research, there has been a decrease in diagnostic evaluations because the primary therapy is recommended as a medical therapy.
And Pantelis mentioned scintigraphy. In research, is there anything extra you're measuring, in patients who you're interested in? We had one question before the seminar about BOLD MRI. Are you using anything in particular that is different in research?
So from my side, I don't really have, I guess, strong expertise in the kind of advanced imaging techniques there. I have seen MRI BOLD and oxygen sensing and different methods of kind of assessing the kidney and the renal artery stenosis. If I can segue a little bit, my interest, I think, tends to be in biomarker-based phenotyping. And I did want to comment that in the Coral sub-analyses, one of the major, probably the major sub-analysis that was very statistically positive or a strong statistical interaction was between the urine albumin creatinine ratio and the randomization status. So this is the idea that there's a renal artery, but there's something downstream of the renal artery, which is the glomerulus. And glomerular health may bifurcate or may change the treatment response. It may even have an interaction where the same treatment could have positive or negative outcomes based on glomerular health. So I can put it in the chat box or the question and answer, but there's an interesting paper from Tim Hendry and the Coral group in 2016 that found a major statistical interaction between baseline urine albumin creatinine ratio and outcome based on randomization, such that people with low albumin creatinine ratio in a post-hoc analysis had benefit from renal artery stent intervention, and people with high albumin creatinine ratio had no benefit from renal artery stent intervention. Now, this is a post-hoc analysis, so we need more data, and we need to kind of verify or bolster, is this a finding that holds up on future verification?
It's very interesting. My conclusion from all of the Astral data from a long time ago wasn't about the degree of stenosis that was described earlier. It was the fact that I considered this a multi-system disease, and you're precisely treating one lesion, but there may be a series of lesions further down the vascular tree. And I think what you're arguing is that the glomerular health and other lesions might be detected by the level of albuminuria. I don't know if, Darren, you looked at that at all in Astral or any of your work, level of albuminuria, or if there's other predictors of benefit that haven't been investigated fully in a prospective trials.
Yeah, so we've done as a long-term outcome analysis of Astral. It's not in print yet. The abstract was presented last year. That's available online, but the full paper should be out early next year. So that was up to 10 years from follow-up. We didn't find any difference in low and high albuminuria groups. The only subgroup where we did see a noteworthy difference was the significant stenosis, so either the bilateral stenosis more than 70% or 70% in a single functioning kidney, where we didn't meet statistical significance, but we had 163 patients fitting within that group, and I think for all-cause mortality, the p-value was 0.051, and the hazard ratio was 0.7. So there were some very encouraging results in there. We in the presentation earlier, it was alluded to the fact that Astral didn't really pick up on enough of the either high-risk phenotypes or the high-risk stenosis groups. So within that small number, we did get some encouraging results for further downstream studies. The difficulty is going to be recruitment, I suspect, because again, within the slides we saw earlier, one patient per site per year in Astral, and that's not even accommodating the fact that some centres recruited 50 or more patients. But again, we looked at other age-related groups, and we didn't find any significant difference. Can I just comment on the early discussion as well about patient selection? We tend to go on the same types of phenotyping as have been mentioned, you know, the high-risk cardiovascular groups, the heart failure, people with previous bypass, peripheral artery disease. One thing I try and avoid is using ultrasound asymmetry as a means to determine whether or not someone may or may not have renal artery stenosis. And that's partly because what you really want is to find someone who's got renal artery stenosis, but who's got good cortical preservation. So if you do an ultrasound with someone and they've got two good-looking kidneys, if they are, you know, for the previous bypass, if they've got peripheral artery disease, they're hypertensive, they've got, you know, the hypertrophic echo changes, you know, the old adage of doing ultrasound to look for asymmetry, you're potentially missing the precise candidate that you would want to revascularize, because they've got that downstream, hibernating tissue, I think was the phrase that was been used in the past.
I've observed hibernating tissue in transplants, particular where you've got 99% stenosis and they've just got enough blood flow to keep their kidney alive, and you put a stent in and they go from anuric to polyuric on the table. So I'm very much convinced that on the really high degrees of stenoses where they maintain perfusion and there is a very specific lesion, that you can have clear benefits. Can I ask you another question that comes from clinical practice, which is there is a lot about selecting people with flash pulmonary edema. I mean, I don't know whether or not how many patients, whether or not you recorded the information on how many patients were, had significant stenosis but were excluded from Astral as a result of people not being uncertain. I remember when I saw the UK Renal Association presentation of the Astral results, that there was congratulations for finding nephrologists that were uncertain about what the right treatment was. And I think that some of them were quite certain about treating people with flash pulmonary edema. Do you know how many people were excluded from Astral as a result of nephrologists being certain, and did that impact on the slow recruitment?
We didn't really put anyone into Astral from our side. I think we recruited about 55 into Astral. We recruited about a third of the people into the cardiac sub-studies as well, but we didn't really put many in with that fitted that phenotype. About 15% of our renovascular patients that come to our service present with flash pulmonary edema, and the bulk of them didn't go through to Astral. Okay, I mean, of the flash pulmonary edema, I mean, I am increasingly of the view that a lot of the flash pulmonary edema patients are not true flash pulmonary edema. They're acute decompensation of unstable heart failure. I think it's important there, again, one of the slides earlier, that it was flash pulmonary edema or acute decompensation of heart failure. Because again, if you look at the Pickering paper and the Mazuris paper that shortly followed it, where they talked about renal artery stenosis masquerading as heart failure, I mean, they were relying on M-mode echo and nothing else. So if you did the same study now and you had cardiac MR and you had an understanding of HFpEF and other presentations, I think you'd acknowledge that heart failure is extremely common. A lot of those, the patients they described as masquerading as heart failure probably just did have heart failure that wasn't identifiable on the M-mode echo that they use. Sorry, slight tangent there.
No, that's fine. I know exactly what we want, the tangents. Do you think Astral and Coral bring uncertainty into the situation about treatment of flash pulmonary edema, and whether or not you could actually now randomize people to revascularization or not? The reason I ask is just that I've seen people who with flash pulmonary edema go into anuric, end-stage renal disease as a result of their revascularization in an effort to try and improve outcomes. And so there is both balance and harm to consider. So I don't know whether or not that would be even something, Rajesh, Darren, you might even consider, or Pantelis, if you were going to do a trial, or whether or not you think the benefits are so clear in the patients that have got bilateral critical renal artery stenosis that you can't really leave them untreated.
Well, actually, this is the real question. I mean, my feeling is that I'm very happy. I can see like big numbers coming from countries like UK or US, and then we have studies from Germany. That study was from there, and some study from Sweden. When we have observational data that are quite, how can I put it, quite solid, saying that those people with flash pulmonary edema, if you revascularize them, you will get a benefit. And the actual there is the actual analysis of the risks associated with renovascular disease, again by the group of Carla, said that the higher risks were associated to the presence of renovascular disease. The higher risks were in the group of flash pulmonary edema. So if you have a patient that is coming with repeated pulmonary edema, so acute decompensated heart failure in the hospital and the phenotype is there, and you have an acute kidney injury every time they are coming, then I think that you need to take the risks and revascularize them. And from my experience, these people are doing quite well, even if they needed dialysis for a couple of sessions. They are doing quite well. Quite well means, in most of the time, that the best case scenario, they will go out and live happily ever after with a GFR of around 30. But if you can just with a single procedure can delay dialysis for a year or two, then I think this is also quite significant result. So this high risk group, I think it's the one that benefits the most, especially when they are treated in centers, when people are knowing what they're doing.
And can I ask a technical question, whether or not treating one kidney is sufficient, or whether or not you need to stent both to treat the risk of flash pulmonary edema? I don't know, Rajesh, do you have a preference? I'm particularly talking about flash pulmonary edema and whether or not you might actually reduce risk by just stenting one of the stenoses.
I don't know if I have a strong opinion. I think it would depend on the risk of the situation, the creatinine, the vital signs. It would be fairly controversial to proceed in these high-risk situations because they're often, multi-comorbid patients with multi-organ problems. Probably you would, if you agreed with the team, say there was an interventional cardiologist and nephrologist that agreed, you would probably do the least harm, which is try to do one, just to minimize risk of atherosclerotic embolization, contrast, etc.
Yeah, it seemed sensible to me. Okay, and Darren, is there anything else you wanted to add? We've got coming to the last 2 or 3 minutes.
Yeah, I'll speak quickly then. Yeah, so with the do you stent one or two? I'll confess that we usually do both, but I don't think we've got justification necessarily for that. The Tina Chrysakou, one of my colleagues, must be nearly 10 years ago, she published a paper on a case where it was a patient with recurrent acute decompensation of heart failure, where we did cardiac MR and various biomarkers before and then serially after revascularization. That lady had a regression of her LV dilatation and LVH, and she had an improvement in GFR. But if you look at the change in the renal MR, she clearly had benefit only on one good kidney, and with hindsight, the other kidney was a bad one from the start. So, and then in terms of do we do a trial in these higher risk groups, the flash pulmonary edema ones? I mean, I know the question you asked at the very start that we'll get a repeat of in a moment talks about do you routinely look for it, but the general consensus seems to be that people aren't that convinced anymore of the benefits of renal artery stenosis. So it will be interesting to know what the answer would be to, what do you do with these high risk presentations? Because if we get a similarly low response, then that would suggest that there are plenty of people out there who wouldn't consider stenting these people at all, in which case that might justify doing an RCT. And then the other group, of course, again, the ones that we seek out, I think, in our clinic, or the group we have the most referrals from, are not the ones who are presenting right in front of you with the acute pulmonary edema. It's the heart failure patients who are suboptimally managed from a heart failure point of view, who get recurrent decompensation. So they are perhaps in that grey area between the acute pulmonary edema and the chronic heart failure. Because we've moved them into two separate categories, haven't we? Either you've got acute presentation or you've got chronic heart failure, but there's plenty of chronic heart failure people who've been recurrent presenters with acute pulmonary edema.
Okay, so what I think I'm hearing, and you can correct me, is that if you've got flash pulmonary edema that we should treat, if you've got less than at 90% stenosis, you should be uncertain, but there is a group around 90% plus with viable kidney who may have either had acute decline in kidney function, have markers of high risk, you think essentially have got rescuable kidney who you would treat. Have I missed anyone out? Or is that the really precise window of opportunity for treatment with these stents?
I mean, so I think there are, I mean, refractory hypertension.
Yeah, and
of course.
and refractory hypertension, yeah.
There are other individual cases, I suspect, aren't there?
I guess I would argue the onus is on us as investigators to demonstrate to people in a convincing fashion that there are populations or subpopulations that need a procedural treatment. In light of the randomized trials, I want to emphasize to the audience that the primary treatment for renal artery stenosis is medical therapy. And appropriate medical therapy is antiplatelet therapy, high-intensity statin, and the renin-angiotensin aldosterone antagonist, and appropriate hypertension control, which typically involves 2 or more drugs, including calcium channel blocker and a thiazide diuretic. Now, as investigators, like I think people on this panel and maybe some people in the audience are potentially investigators, then there's some interesting things on subpopulations, imaging approaches, biomarker approaches, procedural techniques that we have to prove. And I think that question is still an open question for investigation.
Awesome, thank you.
May I add a small comment? I totally agree with Rajesh. And the thing is that at least in tertiary centers, we have a lot of people coming in with refractory hypertension when medical therapy have been tried sometimes or a lot of times, and ACEs and ARBs were not tolerated. So this is a small fraction of people that we can probably have an eye on for possible revascularization. And then if we don't know what to do, then again, with the very few simple clinical rules, we have the patient, we give them, it's not probably, an average dose of an ACE or an ARB, and then we follow them. And if they don't have, a real drop in GFR, then everything is okay. If they do, then we can, again, with this simple test, see if they belong to these specific subgroups, which are mostly relevant to high-grade stenosis, the critical stenosis. So yeah, we agree on medical therapy in everybody, and also we can take advantage of that, do that properly, and then specify for simple clinical practice, everyday clinical practice.
I would just like to add that maybe these people should be put into registry so we can publish our results and compare what happens to creatinine, what happens to blood pressure, what happens to heart failure hospitalizations during follow-up. And maybe potentially we should have biomarker banks for these patients so we can look at urine and protein biomarkers that predict outcomes. But these centers like yours that have these referral patients are a major resource.
Thank you, Rajesh, and thank you, everyone. I think I have to call time now. On behalf of the ERA Journal Club, thank you so much, Marieta, Pantelis, Darren, and Rajesh for joining. Particularly Rajesh for spending his Thanksgiving on the seminar and answering so many of your questions in the Zoom Q&A. We very much appreciate it. We better let you get back to turkey or whatever it is on the table. But before you go, we need to see the results of the poll. So hopefully we can put the poll up and see if we've changed people's opinion. And whilst we're putting the poll up, it's there already. I'm afraid we can't vote again. Just it's the same question again, just asking after listening to the e-seminar, do you or will you routinely consider CKD patients with possible renovascular disease for vascular imaging intervention? I think we've identified what possible renovascular disease is, risk factors, resistant hypertension in particular, and not necessarily just looking for asymmetry in an ultrasound. So we had about a quarter saying always last time. We had about 59%. It looks identical. Everyone knew the answer already. Fantastic. Everyone's incredibly consistent. Well, I guess we've all probably cemented our opinions of where we sat before. So that's great. We've picked the data which fits our opinions, but I'm really grateful again to all of our attendees. Thank you. And please, the listeners, please answer the very quick survey at the end of this. It enables us to keep these e-seminars running. You'll see a link, and please do put the last Thursday of the month in your diaries for the next ERA Journal Clubs. We are going to give ourselves a festive break and skip December. Sorry, Rajesh. And you'll be back in January when Jennifer Lees and Kat Stevens will be presenting the e-seminar. But it's goodbye from myself, Will Herrington, and the rest of the ERA team, and happy Thanksgiving, everyone.